With the lack of privacy in today's culture and the risk of being canceled, we created this podcast to give people a chance to share their stories with complete transparency, honesty, and total anonymity. I'm your host, Horrible, that's with the W, and I am a fox.
And I'm Doggo, and I'm a black lab, and today we're drinking some red wine because our guest has some blood on her hands.
Also, I'm very Italian.
Yeah. So please welcome our next guest, Tati the Raccoon.
Yes. I'm Tati the Raccoon. I'm drinking a nice blonde ale. I don't know what the name is. I don't want to try and pronounce it. Is it Live? I really don't know. It looks like an L. Okay.
Hi, Tati!
So, why are you a raccoon?
I'm a raccoon because, number one, I think they're really cute. I don't care what anyone says. I will go up and try and pet a raccoon. Yeah, I know it's crazy. I don't care. Also, I just recently learned that raccoons tend to go to the bathroom together to do communal shitting. I thought that was really funny. So I'm like, yeah, let me buy that. That seems like a cool activity to be doing together.
It's certainly like intimate,
that's very intimate. Like,
I once read a book that was saying like, the next level of intimacy is not sex, it's when you could poop in front of your partner.
I mean, yeah, that's definitely oddly enough, like bigger vulnerability.
It really is. Like, I had to say, it took me more time in my marriage to get to that level than anything. Like, my poor wife was just like, she don't care.
All right, so what do you do?
So my official title on my license and on paper is medical laboratory scientist, but everyone knows, well, the people that know we exist knows us as medtechs. And basically what I do is, when you come to the hospital and they draw your blood or they take any urine from you or any body fluids, they send it out to the lab, and it's my job to either analyze it manually or put on an instrument, interpret the results from there, make sure everything matches with what the patient is presenting as, and then releasing and calling people accordingly if anything's very abnormal.
So you don't draw the blood, you just do the analysis behind the scene.
Yeah. Again, there are small hospitals that don't really, they don't have the staff for that. So they will have the tech do both drawing the blood and testing of the blood. But most hospitals here, or most hospitals that I've worked at, normally don't have the med techs draw blood.
Gotcha. Now, you mentioned that sometimes even that the hospital staff doesn't know what you do and such. So along those lines, what do the hospital staff think that you do? And like, does that cause problems for like your job responsibilities, or do they make you try to do things you don't want to do?
Number one, are we allowed to curse?
Yeah. Fuck yeah.
So dead ass, every single one, and a doctor or a nurse, that if I'm at orientation and I tell them, oh, I'm a med tech, they're like, oh, so you draw blood? And I'm like, how have you been doing this for so long? You still don't understand who's giving you results on the other side of the phone. Just completely, they don't know what's going on.
I like to think they think it's like magical fairies or something.
It's really invisible. Even at college, I didn't know that was a field that existed. I just happened to come upon it because I was volunteering at a cancer research lab, and I figured out I love the lab stuff way more than I cared about research. And she's like, there's a whole degree for this, right? And I'm like, what? No one's telling me.
So wait, what does the degree entail? Like, what is it? Like a bachelor's degree?
It's a bachelor's degree in medical laboratory sciences, 4-year degree, and then you have to do clinicals, obviously hands-on stuff to make sure you know what you're doing, and then at the end you have to take a certification exam to get your license.
Okay.
And both of those things you have to maintain like every 2 years. You have to take continuing education to maintain your knowledge in the field and to be updated.
Is there any test you absolutely hate doing? You just despise it?
Okay, in the past, it used to be semen analysis. It's not my favorite. There's something about like as soon as they like go in the cup and they it just stays still for like too long, and then the med tech unfortunately has to unscrew that and get a whiff of whatever.
Oh.
Yeah, every time I would be like, okay, get it together. It's your job. But at the moment, I hate urinalysis because for some reason, when they send the urine cups, they don't close them. Oh. So I just get a bag of wet pee everywhere. There's pee on the cup. I hate it, and And this current season, that's my most hated test.
Wait, does that ever cause like cross contamination for the?
They're not supposed. That gets rejected because if the analysis comes back positive that you have some sort of infection going on, micro has to culture that urine. So if that urine has spilled from the sterile cup into a non-sterile bag, the culture is moved.
You're those people for passing drug tests.
It does not interfere with the drug testing, though. I don't think that.
Well,
Contamination is not, yeah.
if someone needs to buy some time, right? And they just make a really sloppy sample and they're like, no, rejected, come back in 2 weeks.
So in case anyone's curious how they know that, if the pH is, so the normal pH for actual legit urine is between 5 to 8. If it's beyond that, either it's a really, really old urine, if it's very alkaline, or you've fudged it, or if it's too acidic, we know this is not urine. What is this? Or it's like a perfect like 7 and it looks completely like what? Yeah. Like they catch that you're using something else other than actual urine.
So you do.
Yeah, good to know.
You do analyze urine for a drug test.
Yeah.
Okay.
The only thing we don't do, so toxicology kind of measures even further by LCMS method, but we don't do that. We just kind of, it's a qualitative thing, negative or positive for
Marijuana,
THC, cocaine,
okay.
Stuff like that.
So I've worked in different labs as a chemist, and one of the labs I worked in, they had just a collection of SOPs from I guess it's a lab that has been different industries,
Mm-hmm.
and they don't even check what SOPs are there. So there was literally hundreds that we had to read,
Okay.
and only maybe 20 of them were associated to our labs. But one of them was for drug testing
Mm-hmm.
and what would classify as adulteration. And so one of the old school techniques to pass a drug test was you drink a lot of water, and then that dilutes everything.
Mm-hmm.
And, it's hard to convince someone that your urine is that diluted and it doesn't look the same color. It needs to have
Right.
like a certain yellow color to pass, right?
Yeah, and that's not to say there isn't colorless urine out there. That's possible. It can be legitimate. It's more like it's even included in our process when we get the urine, we have to test the pH to make sure if it's out of range, it's not going to interfere with our ability to tell if you're positive for something.
So, one of the techniques was to dilute your urine to the point of, basically you wouldn't get any analytes to come out, and then you would take niacin, but then you just get one
To get
peak.
color.
Yeah, and you get one peak of niacin and everything else is flat.
That's
So then
hilarious.
the new thing that I heard was to take a vitamin B complex so that you get a bunch of various peaks.
Oh, to get more analytes in your urine to fit the specific. Okay.
Exactly. And then some
Um,
of the retention time on some of those peaks came out at the same time as drugs. So it kind of would like overlap a little bit. And if it was supposed to be a quick positive or negative, there
Yeah.
was no way to determine it.
Huh.
But maybe,
Um,
maybe you're learning that today.
Or do you got
No.
a better idea for one or something?
I don't think I've seen. Oh, actually, I did have a recent case that surprised me. So, everything is it's technical and highly controlled. It's inspected biannually or it's every 2 years. So everything's a tight ship. So for stuff like that, we use quality control. That's the same matrix as the fluid we're testing. So we had an instance where the nurse calls. They're like, "Hey, we suspect our patient might have been doing coke in the bathroom. Can we just send like a swab and just stick it in water and then you guys test drug testing?" And we're like, the instruments are not validated to test drugs in water. It's validated to test drugs in blood and urine.
Process through the
And
body
if we
first.
do that anyways, it's a major violation of the guidelines of the lab because technically you don't know if that result's actually accurate.
Gotcha.
It hasn't been validated. So, but they'll still try and find ways to go around it and send it to you to get you to trick you into testing it. So,
Gotcha. So my vitamin B technique still might be
yeah,
valid.
I mean, clinicians do it, so,
Well, while we're on the subject of all the sample drawing and all these different techniques, what actually happens to the samples once they're given to you?
Okay, so let me pretend I'm like in the ER. You come in, you got your blood drawn, possibly urine. So they package all that up, label you up, send us to the lab. So the lab's kind of separated between pre-analytical, which is like the lab assistants or phlebotomy that receives the blood, just receives the orders, and then they bring the blood according to whatever department it needs to go to. So let's say your blood is going to chemistry. I go in, I put the blood in a centrifuge, spin it at a certain validated RPM, and then we analyze the plasma or the serum. And then depending on what labs you got going on, let's say you have critical electrolytes like your low potassium. I'm having to call a clinician, I'm having to call a nurse to make sure that they know, hey, this person's abnormal. You need to start doing something. You know, not that it's not communicated that way, but that's what it is. And I think I kind of lost what the question was.
No, you're good. It was just seeing what actually happens. But so you literally grab the sample, start working on them. It sounds like.
Yeah, and then a lot of that is making sure the specimen is of good integrity. That's part of your job. So making sure it's not hemolyzed. You can only find that out, by the way, guys, by centrifuging the blood. That's another miscommunication between nurses and med techs, because they legitimately sometimes believe we're purposefully hemolyzing blood in the lab, and it's just like that's not a thing that happens.
For the audience, what is hemolyzing?
It's when if you're using like a needle set that puts too much pressure while you're drawing the blood, it can kind of shred the red cells that's coming out. So if they lyse, it's leaching potassium. So when we measure that, it's not your actual potassium. Those cells got lysed, so it spiked it up falsely. So we have to reject those. You have to go back and redraw them, because that's not going to be an accurate clinical picture. But to them, because we call so much, just because depending on who works, different phlebotomy skills, you get either really good samples or really shitty samples, and you have to keep redoing it. So if you ever wonder why they come back and get more blood, that's what's happening in the background. Something was wrong with the first set that they drew. You'd have to redo it again to get more accurate results.
Oh my God, I finally have something to tell my dad.
Yeah, if you ever had to weigh and you're like, man, what's going on? There's like so many different points from where it gets drawn to when it gets to the lab, and then from the lab to us. So many like little pauses that causes wait times, you know?
So most of those pauses, you would say it's like due to science, just due to like not necessarily management, not people not doing their job. It's just
it's due to science, and it's also due to staffing and the level of like pressure they're on. You know, how many patients, what's their workload? Because the more you're juggling, the more you tend to kind of slip up. You're human. Human errors happen. So you kind of slip up. Maybe you drew this assessment and you thought you sent it, and it's just been sitting there on this table for 10 minutes, right? That's the situation that happens. So therefore, your stay has just been extended by 10 minutes. It gets to the lab's overwhelmed. Your stack is all the way behind. Another like 10 minutes. So that's why people end up spending so much time in the ER. Like the lab and I think imaging is their two bottleneck of the hospital, and that's what keeps you there for so long.
Do you guys think you have more volume than like other portions of the hospital?
We definitely do, and if it's a well-run lab with nice new instruments, then you're able to handle that load, because they build those instruments to run about like thousands of tests at once, right? But if you're working at a facility where they're not keeping it, and your instruments are not always cooperating with you, major delays, no matter how hard we try to do quality control, make sure everything is accurate, sometimes you just can't help a bad instrument, and then that falls on management. At that point, it's not on us. We're doing our best with like sticks,